Welcome to this show discussing problems and issues of health with Dr. Alcena. For this segment of the show, I'm going to continue to talk about strokes. As I said the last few shows that I've done, stroke is a very, very common medical problem. Each year, 795,000 people in this country suffer new or recurrent strokes. 600,000 of these are first stroke, 185,000 of them are recurrent stroke. And worldwide, you have 12.7 million people suffer a new stroke every year in this country. Every 53 seconds, somebody is suffering with a stroke in this country. Every 3.3 minutes, somebody dies of a stroke. Serious, serious problem. There are, of course, different types of strokes. And in this segment, we're going to begin to treat the different. First of all, I'm going to tell you the different types of strokes, and we're basically going to begin to treat them for you. You have atherosclerotic stroke, represents 61% of all the strokes. Lacunar stroke, 20%. Embolic stroke, 24% of all the strokes. Hemorrhagic stroke, 10% of the strokes. And then subarachnoid stroke represents 7% of all strokes. Another type of stroke, of course, ruptured aneurysm. You have bleeding from AV malformation, TIAs, and those are the different types of strokes. Now, we are now going to talk. I'm going to talk to you about how we go about really treating these strokes, how to determine which type of stroke it is. Somebody shows up either in the office having a stroke, you have to rush them to the ER, or they show up in the ER, either brought there by the families or by EMS, and they're having a symptom that you think could be a stroke. Either they're paralyzed, they're aphasic, they may be having a seizure, and so on and so forth, and you determine that it's got to be a stroke. It's very important to determine how long ago, how many hours ago the symptoms began, because that have significant clinical relevance. So you're going to, after you evaluate the patient, take a history either from the patient or from the family. If the patient is aphasic, then you proceed to send your blood work, get your vital sign out of the way. Very, very important to do an EKG, and I'll tell you why shortly. Then you proceed to get a CAT scan of the brain. Just a simple CAT scan without any contrast. Why is that important? Well, it's important because you need to know if the patient is bleeding into the brain. The CAT scan will tell you that immediately. That the patient have a tumor, because a tumor of the brain can have the mass effect that can also having similar symptom as a regular stroke. And or if the patient has had an old stroke that's older than about 2 weeks, you could pick that up on the CAT scan of the brain. If it is an ischemic stroke the patient is having, you will not see it on the CAT scan of the brain immediately, because it takes time for the CAT scan to show that. If it's a bleeding stroke, however, you need to know right away. Why do you need to know right away? Well, because you're going to want to give the patient to take certain decision. If the patient is bleeding, the approach is completely different. If the patient is not bleeding but still having the stroke, and you don't see it on the CAT scan, you may see old stroke but nothing fresh stroke, then you proceed then to do an MRI of the brain / an MRA of the brain. The MRI is crucial, the MRA is crucial. The MRA will show you the vasculature of the brain to see if the patient has an aneurysm that's ruptured, or if the patient has stenosis in the vessel. Stenosis means there is a blockage in the vessel that's preventing blood to go through, etc. Those things are crucial, because if the patient is bleeding into the brain and or the patient has stenosis, then you want to call a neurosurgeon immediately. Immediately, because there's something the neurosurgeon can do surgically to try to fix the stenosis, to open it so that blood can go through, to prevent the patient from having a chronic paralysis, stroke, etc. And if the patient had a ruptured aneurysm or an AVM that's ruptured, the reason why I mentioned AVM and I mentioned the seizure, because sometimes people who have AVM some of them have seizures throughout life, and they may present with a seizure first, and to find out that the reason why they're having the seizure, even though there are many reasons for seizures. It may in fact be because they have an AVM and they've been having seizures all along. That may be why. And it's an AV malformation. And what that is that the junction where the arteries meet the vein, there's a malformation there. Then that can cause the patient to have seizures, and that can also cause bleeding to occur. So now that you got your CAT scan, you got your MRI, you got your MRA, and you got your physical done, now you know exactly what you're dealing with. Then you know precisely how to proceed. And I mentioned last week, one of the things that is super important, if the patient does not have a bleeding stroke, while you are getting in touch with your neurologist to come in, you may in fact want to give the patient aspirin, because the aspirin can prevent platelet aggregation that can prevent the patient from having a full-blown ischemic stroke. And other than the aspirin, if you don't want to give aspirin right away, you could give TPA. The TPA can be given by the emergency room physician even before the neurologist got there, because that's crucial. Because the faster, the quicker you give the TPA to let blood to flow to restart through the process to the area, then you could save brain tissue from having permanent damage. So those are crucial decisions. As I said last week, and I'll say it again, you can't practice clinical medicine, clinical neurology, clinical surgery, clinical anything if you don't have knowledge, experience, and judgment. Let me repeat that. It's knowledge, experience, and judgment. These are the three things that you need in order to practice high-quality medicine, high-quality neurology, high-quality surgery, high-quality pediatrics, whatever. You have to have those three things. Protocols are good for research, and protocols are good for a whole lot of other medical legal stuff, blah, 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 blah. But when you're at the bedside, you need those three things to practice high-quality medicine or whatever it is you're practicing. That's just the way the system works. That's just the way it is. So now you have to decide if the patient will have TPA based on what you just saw in the MRI. You got to move fast, because the faster you move, the more brain tissue you could save for this patient, making the situation much better for the future. If the patient is bleeding, then you have to back off and call your surgeon, neurosurgeon right away to try to make the bleeding stop via neurosurgical procedures, blah, 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 blah. So now that, let's talk, for instance, I say to do an EKG. What's the value of the EKG? Well, you examine the patient. If the patient is having atrial fibrillation, and if the atrial fibrillation that's causing the patient to have a stroke, you could tell that on physical exam. You could tell that the patient is having irregular heartbeat, but you wouldn't know exactly what the irregularity is unless you do an EKG. It will tell you. It's also crucial. The patient may have atrial flutter, but atrial flutter is irregular. Atrial flutter is very important, but it's irregular. So the EKG will tell you the difference between atrial fibrillation and atrial flutter, and or other cardiac arrhythmias that may be associated in the patient problem, etc. Again, let's take a moment to talk about the aspirin, because what's going on nowadays, people are giving aspirin, 2 aspirin. Once they do the CAT scan of the brain, they see there's no bleed, bango, they give the patient 2 aspirin. Each aspirin is 325 milligrams. Each baby aspirin is 81 milligrams. And I'm here to tell you, I don't care what anybody says, giving somebody 325 milligram as 225 milligram aspirin when you're dealing with a stroke is absolutely, completely, totally the wrong thing to do. I know it's a heavy statement. I will explain why. What is it you're trying to do when you give the 2 aspirin? You're trying to prevent platelet from aggregating so that the clot doesn't form, to try to help the problem. However, there's an issue. You have to remember something. When you prevent the clot from forming, you have to pass via a substance called thromboxane A2. Otherwise, it won't work. So you have to affect the mechanism of thromboxane A2 in order to prevent platelet from aggregating to achieve your goal. Well, how about that? Thromboxane A2, the more aspirin you give, the more you are affecting the action of thromboxane A2, the more active the thromboxane A2 is doing its thing, it's secreting a series of vasoconstrictive material. That's correct. The more aspirin you give, the more you're activating thromboxane A2, and the more you activate thromboxane A2, the more of the substances that are vasoconstrictors you're secreting into the system, causing the vessel to constrict. However, all of us were born with a substance called prostacyclin. Prostacyclin is our God-given vasodilator. It keeps our blood vessel open. Guess what we're doing when you give too much aspirin? You are completely eliminating the benefit of prostacyclin. It is completely, its benefit that we have that keeps our blood vessel open is just been eliminated because you give too much aspirin. So prostacyclin is no longer here to protect us. The vasodilatory process is eliminated, and you are causing more vasoconstriction. What you are trying to do is to prevent platelet, but in so doing, you are making the situation worse because you give too much aspirin. You could give too much aspirin. You could give all the aspirin you want to prevent arthritis. You could give all the aspirin you want to bring a fever down. You could give all the aspirin you want to interfere with inflammation, but you don't need 2 aspirin to block platelet formation. You don't. 81, as a matter of fact, 25 milligram is sufficient. 50 milligram will do the job. So failure to comprehend platelet physiology is causing the situation to be worse. That is not the intention of the people who are doing it. They just simply do not understand how it works. In fact, 25 milligram of aspirin is enough to knock out platelet qualitative function for 7 to 10 days. The platelet in the body will not aggregate effectively if I give you 25 milligram of aspirin. The only reason why I take 81 milligram of aspirin today is because I don't have a tablet for 25 milligram. And the 81 is so tiny, you have difficulty breaking it in half. Let me give you an example. There's a medication that is being sold as we speak called Agrinox. Agrinox has a 200 milligram of dipyrimidine in it. That's a vasodilator. And it has 25 milligram of aspirin in each one of those tablets. How about that? So this particular company, which is clearly very smart, and Agrinox is used to treat transient ischemic attack when you're having little mini stroke inside the brain, to open the vessel and also disaggregate the platelet. That's all you get, 25 milligram in each, and that is fantastic. So therefore then, it is not my job to try to teach these people what to do. That's what I teach my students. And I'm no longer teaching on the ward. When I were teaching there, I used to teach my interns and residents that. Therefore, you don't understand the system, then you should ask for help or go to lectures. They have lectures all over the country. Every 7 days a week, people are giving lectures. Hematologists in academia, there's lectures every week, every day. 7 days a week, they're giving lectures of different type. Go to the hematology meeting. It's coming soon. So you can learn these things. Let me repeat that. There absolutely is no place to give somebody who is having a heart attack two aspirin. There's no room for anybody who's having a stroke, ischemic stroke, to get 2 aspirin. You're making the situation worse. Somebody's having a heart attack. My God, all they want is blood flow and oxygen flow. They want the vessel to be open so the blood can't grow to the area of ischemia to prevent a heart attack. But this feeling telling you you're not doing that, you're not preventing the stroke or the acute ischemic attack in somebody's heart when you use 2 aspirin. For what purpose? For what are you trying to do other than cause somebody to bleed more? You're increasing the incidence of GI bleed significantly. Somebody go there, they have cardiac bypass. They send them home with aspirin plus heparin, God knows what else. What are you trying to achieve? You don't understand the concept. How about prostacyclin? If you don't know what prostacyclin, go and look it up. It is a native vasodilator. What is the effect of aspirin on prostacyclin? It render it gone, eliminated, ineffective. So therefore, the native vasodilator that all of us have, that we need to keep our vessels open, is being wiped out by giving somebody too much aspirin. Is that hard to comprehend? And I don't have a monopoly to this information. That's the thing that bothers me the most. This is information that's out there. Forget about the fact that I put in this book. You don't like me, you don't like to read my book. That's your problem. When I'm dead on go, when I bet you this book will become much more valuable because people, they don't have to hear my voice anymore, then they can find out, oh my God, I have stuff in this book that I can guarantee you that's going to come the standard 10 years from now. And people are going to be scrambled around all over the place to take credit for it. The same way they're taking credit for the fact that I came up with the idea of male circumcision to prevent the incidence and death rate from HIV/AIDS in 1986. People are going crazy now, waiting for me to die so they can apply for the Nobel Prize for it, because I don't have the connection to do that, but they do. As long as I'm alive, they're not going to get it because the WHO and Lancet and everybody else know I did that, and it's all over the literature. But once I'm gone, oh my goodness, you can hardly wait. I had a situation where several years ago, a doctor in Westchester was receiving an award that is named after me. And this man was so kind, so nice. He called me after he looked me up to say, I owe you an apology. I said, why are you apologizing? He said, you know what, doc? I sat for years on these committees, national committees. The fight, the argument that's going on, people trying to get credit for this. It's only now that I just look you up before I'm getting this award. I realized that, oh my God, I could kick myself in the butt that, oh, I never defended you. It's only now I know that you're the one that came up with that idea. This is a man who's, and then all the stuff that was going on during the previous administration, all the aid meeting, ceremonies, dinner that took place once a year in Washington, D.C. I never was invited to that. Who am I? I'm a little poor Haitian peasant. They don't want me there. They don't like the color of my skin. They don't like my accent. They don't like the way I speak English. Besides, I'm too vocal. And these people, oh my, you have no idea. I mean, the dinners, the international reunion that took place in Washington, D.C. over the many years in the previous administrations, every year there was huge. This star, that star, gala, black tie, all the rest of it. And I was never invited, not even once. Why would they want to invite a poor Haitian person like me who happen to be an orphan on top of that? They don't want that. All these people there, and this poor, I felt bad for the gentleman. I tell him, man, I congratulate you. You deserve this award. Take the award. It's not your fault. Blah, 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 blah. Okay? So suffice it to say, my students know that. My patients know that. The people in academia who gave me that M.A.C.P, Master, American, they know that. That's all I care about. As I said, I have no interest of being accepted by anyone. But I dare you not to include me. That's right. That's a different thing. All right. So suffice it to say, therefore, then, to get back to stroke, that patient needs 81 milligrams of aspirin if he or she is not bleeding into the brain. That will go a long way to prevent platelet from aggregating, and it lasts for 7 to 10 days, allowing blood flow to be reestablished, and it keeps prostacyclin intact. The vessel remain open, and much less of those vasoconstrictive substances from thromboxane A2 get secreted, and that job is done. If you don't want to give the patient aspirin, you could give TPA, but ultimately this patient will wind up on aspirin anyway as part of the continued treatment for this patient, because aspirin is fantastic. Whoever created that medication, boy, they deserve praise for the rest of life, for the rest of eternity. Suffice it to say that now that you've done that, your neurologist is on board, the patient is being admitted, you have to set up a seizure profile, seizure protocol to make sure the patient doesn't have a seizure. The hospital nurses and everything, they know how to do that. And then you keep the patient on the aspirin, control the blood pressure, do all the other stuff that needs to be done. And then when the appropriate time comes, the patient goes to physical therapy. Physical therapy is crucial. All sorts of stuff get done, and the patient is being rehabbed. And they have some of the best rehab centers in Westchester, Berk amongst them. Berk is the top. They know what they're doing. They're much better at this stuff than I am. So the patient get the physical therapy, and then try to get the patient back in shape. And then the key thing, whatever the problem is that is underlying that, is it diabetes, is it hypertension, is high cholesterol. You try to control this very tightly. If the patient is found to have a thrombophilia, of which there's a dozen different types, that's crucial. You deal with that. If the patient turns out to have a cardiac problem that is of like an atrial fibrillation, then the patient subsequently may be switched over to one of those factor 10 inhibitors, even though aspirin is quite good. But if the patient had, let's say, some kind of abnormality in the valves, so on and so forth, aspirin may not be appropriate, then the patient can be placed on any one of those factor 10 inhibitors, so on and so forth. If the patient is found to have a thrombophilia of one type or another, that is, thrombophilia is something in the patient's blood that causing the blood to become too thick, that leads to the stroke, then of course that patient has to remain either on Coumadin or Xarelto or one of these things for life, and so on and so forth. So that's really how we go about it. And then keeping in mind that it is crucial to control the patient's pressure very tightly. But on top of that, you have to understand there are other stuff that I haven't even touched upon that can also be associated with or in fact cause the stroke. It isn't just the stuff that I mentioned. It's not always hypertension. It's not always diabetes. It's not always atrial fibrillation. It's not always high cholesterol. The patient may have a vasculitis that is associated with some sort of autoimmune phenomena in the body. So when you're evaluating the patient, at the time you're doing all your tests to deal with the stroke, always remember to send a sedate. Always remember to send an ANA, even though the patient may be hypertensive. But the patient may also have these other issues, and you don't want to miss them. Remember, when you come in contact with a patient, you may have one or two chances to do the job right. And if you miss that opportunity, you may not get it again. So whenever you have that opportunity, be very thorough. Don't leave anything for tomorrow that can be done today. That's my philosophy. So check the patient, do a lipoprotein A, do a homocysteine level, do a protein C level, protein S, antithrombin 3. If you're dealing with a woman who has a stroke, who had a pregnancy, do antiphospholipid, do all these things. That's maybe your only chance to do that. If you miss that opportunity, he or she may not give you another chance. And then somebody come down the line later, some smart guy, come up with these things, and the blame wind up on your shoulder because you forgot or you didn't know how to do these things. Simple to do a surrogate. You're going to do a blood count anyway. The same lavender 2 can be used to do a surrogate. You can do blood chemistries anyway. What is the big deal? So you add an ANA. If the patient has vasculitis, the surrogate will be very high. The patient has a stroke because of blood pressure, that's not going to cause the surrogate to become elevated. The patient has a stroke because of high cholesterol, that's not going to surrogate to become elevated, so on and so forth. So right away, that raises a red flag. Listen, I'm not asking you to practice medicine the way I do. Because as I said before, without any arrogance intended, there's clinical medicine, there's Valiere Alcena clinical medicine. And across the world, wherever you go, there isn't a country that has oxygen and the sun and water in this world as we speak, that I don't have people there practicing medicine. I had the opportunity, the honor to teach how to practice clinical medicine. And to this day, I help them from Christmas, send me cards. They're still doing great show. They're doing the Valiere Alcena way. Who taught me how to do the Valiere Alcena? I taught myself. That's right. And I went to some of the best. I went to one of the best medical schools in the country, one of the best training program in the country. And yet, 80% of what I do today, I learn on my own. Nothing negative about my training program, nothing negative about medical school. They're fantastic. But the thing that I do today, the people who taught me, not making excuses for them, they didn't know these things. They didn't exist. They did the best they could with what they had to teach me, and they taught me well. But it was my job to keep learning so that I can sit here and talk to you about these things. So therefore, the stroke, therefore, has to be taken into wide consideration, different things that can cause it. So once the patient is put up on the medication, the cause has been identified, then the patient is going to physical therapy, all this other stuff that these people do. They are fantastic at what they do, the physical therapists. Then your patient then has to get back to, the idea is to try to get the patient back to as normal situation as he or she can get. Okay, because let me tell you something. There are many, many, many complications of stroke. And when I do the next show, I will take it upon myself to show you the scary things that can happen to a human being who have had a stroke. The complications can be, in fact, the vast majority of the time, it is the complication that can lead to the demise of the patient. So then you need a hard-nosed, highly, highly knowledgeable clinician that's going to be in charge of the care of this patient going forward, so that he or she can be constantly paying attention to these possible complications as to prevent them from developing that, in fact, can cause the demise of the patient. Listen, I want to stop here until I see you again. This is Dr. Alcena saying so long and bye-bye.